Chapter 16 allows us to focus on fluid and electrolyte replacements. Fluid and electrolyte balance is necessary to maintain homeostasis. Intake must be equal output to maintain fluid balance, and the body consistently strives for equilibrium. The kidneys and the respiratory system, endocrine, as well as the GI and integumentary systems help regulate fluid and electrolyte balance. Electrolytes are substances that separate or dissociate into ions in solution. They are abundant in both the intracellular as well as the extracellular fluids, and these ions can either be a positive charge, which are known as cations, or a negative charge, which is known as anions. So let's take a closer look at body fluids. Osmolality of body fluids can either be measured if we're looking at isosmolar, which is the same proportion of weight of the particles, and water. If we're looking at hypoosmolar, fewer particles than water. Hyperosmolar, which is more particles than water. And the normal serum osmolality is 280 to 300. Tonicity is used primarily as a measurement of the concentration of IV solutions compared with the osmolality of body fluids. Fluid replacement is essential. Two principles stand out when considering homeostasis and fluid and electrolyte imbalance or balance. The first principle is the ions and cations must be balanced within each compartment and remain electrically neutral. The second principle is that the fluid compartments remain in osmotic equilibrium. When nurses are administering fluids to our patients, we must take this into consideration. There is many factors that contribute to or influence the patients whenever we are replacing fluids. All routes of fluid intake and loss must be considered when assessing fluid balance alone. Generally, guidelines may be used as the basis for establishing fluid needs. What is normally recommended is in a healthy adult, there is 3.7 liters for a man and 2.7 liters for a woman, or approximately 3 to 40 milliliters per kg per deciliter. Patients lose water daily through a variety of different routes. We've already talked about respirations, through the skin in perspiration and evaporation, and also through the urine as well as through the feces. These are accessible losses. However, they're not measurable. The minimum urine output for an adult should be 0.5 to 1 liter per kg per hour, or 35 to 70 mLs per hour, is what is recommended for a 70 kilogram person. When nurses replace these fluids, we have to know the differences in regards to what type of IV solutions are out there and how they fit into the general classifications. There are 3 different general classifications of IV solutions used for fluid replacements: crystalloids, with or without added electrolytes, colloids, and blood products. If we're to talk about crystalloids, they're a solution that contain fluids and electrolytes and are able to freely cross the capillary membrane or capillary walls. They do not contain any proteins, which are necessary to maintain osmotic or oncotic pressure that prevents water from leaving the intravascular spaces. The crystalloids are used to treat dehydration and electrolyte imbalances and as short-term maintenance fluids. These crystalloids cause early plasma expansion but have a shorter duration of action than colloid solutions. To break it down even further, they're broken up into isotonic, hypotonic, and hypotonic solutions. Isotonic is the same approximate osmolality as the extracellular fluid that's inside of the body. There is no effect on the red solutions are primarily used for hydration and to expand the extracellular volume. Hypotonic solutions exert less osmotic pressure than the extracellular spaces or fluid, which allows water to move to and from the cell. IV fluids of hypotonic solutions result in an increased solute concentration in the intravascular spaces. This causes fluid to move into the intracellular and interstitial spaces. Excessive infusion of a hypotonic solution may cause hemolysis, decrease blood pressure, and decrease IV fluid volume. However, when we're considering a hypertonic type of solution, they exert even greater osmotic pressure than extracellular fluids. So this can result in a higher solute concentration than the serum. When administered, hypertonic IV fluids pulls water from the interstitial space to the extracellular space via osmosis and cause the cells to shrink. So patients receiving this type of solution must be monitored very closely for signs and symptoms of circulatory overload. If we are to consider administering our patients a colloid type of solution, this does contain a protein and other larger molecular substances that increase osmolality without dissolving in the solution. Because of their size, the particles are unable to pass through the semipermeable membrane of the capillary walls and stay within the vascular spaces themselves, and they are known as plasma expanders. However, when we are giving blood and blood products to our patients, it can include a whole blood, and the components can be processed through several different methods. The blood produces red packed blood cells, plasma, platelets, and a cryoprecipitant is what happens with these type of products. Plasma can be further processed into a volume expander, and it definitely can assist with coagulation factors whenever it's going to be there for concentrates and immunoglobulins for our patients, right? We want to make sure that with these different administrations, RBCs are approximately about 350 mLs per unit. So whenever we are getting ready to infuse this, it's important for us to make sure that we understand how it functions and it allows for increased oxygen carrying capacities with a very smaller volume for therapy alone. As stated before, crystalloids replace and acts as maintenance therapy and can be used for an isotonic type of solution. D5 in water or plain normal saline or lactated ringers are examples of isotonic solutions. Examples of crystalloids are D5W and half normal saline solutions, which are hypertonic type of solutions, as well as D5 and D10. D10, which is also considered another hypertonic solution. Colloids are volume expanders for our patients, and one of the major volume expanders that patients receive is the hetastarch. The hetastarch is usually given for patients who definitely go through a process of hemorrhage or excessive blood loss, and you want to make sure that you give your patient a volume expander so that it can prevent the patient from going into a hypovolemic type of shock. As discussed on previous slides, the blood and blood products these are examples of blood and blood products. Whole blood or packed red blood cells would be given to our patient if we want to replace if the red blood cell count is decreased and we want to promote more oxygenated blood throughout the body. If we're going to give our patient plasma, fresh frozen plasma, it would be there as a volume expander as well as assisting with any type of risk factors. If our patients are at risk for bleeding, we want to control this because it would affect the patient's coagulability. Of course, albumin would also be considered another product that would be there to assist with our patients that was discussed before who have severe diagnoses of anasarca or have problems with fluids being in the interstitial spaces, and we want to pull the fluid back inside of the cell. We would use albumin for that. When it relates to the nursing process and fluid imbalance, again, it's important for us to remember ADPI. Assessment of our patients for any kind of risk factors for fluid volume deficit or fluid volume excess is essential when we're trying to collect information on how to properly care for our patients. We want to look at the patient's history that might put them at risk or contribute to the fact that they may have a fluid volume deficit or a fluid volume excess. We're going to differentiate between what causes these issues and assess our patients' vital signs to understand what the baseline values are and report, obviously, any type of abnormal findings. We always want to make sure we look at the lab values because we want to look at plasma or we want to look at serum osmolality because it's the primary indicator to say if a patient has or assess the patient's hydration status. So we would determine if the patient has adequate urine output based on the patient's weight and, of course, the urinary function or the renal function for the patients. We always assess what the IV fluid order is for the day. We always want to know what the infusion is, how fast it's supposed to be, and basically what potential things could occur with the different type of solutions that our patients are going to be administered. We could possibly assess the patient's weight to see if there's going to be any excessive weight loss or excessive weight gain. When diagnosing, the patient might have a fluid volume deficit or the patient might have a fluid volume excess. So these are all things that we would pay attention to when we're diagnosing the patient. Planning-wise, we want to take a thorough intake and output over the past 24 hours. We want to assess our patients and make sure that they understand what the risk factors are for fluid volume deficit and for excess. When we're intervening for our patients, in general, again, monitoring the vital signs to know what the baseline is and to report any significant changes if they do occur. Monitor the different types of fluid that's present. How fast it's supposed to be. Is the pump set correctly? All pertinent information when we are going to be evaluating our patients. And we have to follow strict aseptic technique when we're going to be inserting an IV for our patients to make sure that the IV site is patent and does not show any type of complications in regards to phlebitis and infiltrations. If the patient does have a fluid volume deficit, we want to make sure we administer an isotonic type of solution. We want to monitor their vital signs and assess to see if the patient has signs and symptoms of dehydration. If the patient has a fluid volume excess, we're also monitoring to see what the patient's vital signs will be, what the lab values are, the BUN and creatinine levels, hemoglobin, and hematocrit, because obviously if it's an excess, it definitely could affect the patient's red blood cells. Teaching what those signs and symptoms are essential for our patients and for them to report any signs and symptoms of nausea, vomiting, and diarrhea, a weight gain, and of course, once again, cultural considerations are things that we would definitely take into consideration and evaluate the patients to see if they have maintained or met the goals that were set. Moving on to the evaluation or maintenance of our electrolyte functioning. We know that potassium is the major intracellular cation, and sodium is the major extracellular cation. We would also be evaluating how calcium and magnesium, as well as chloride and phosphorus, have an effect on our patient's body. As stated before, we know that potassium is the major intracellular cation. Potassium is essential for neuromuscular activity and cellular metabolism, and potassium levels does affect cardiac and skeletal muscle activity. So the function is the transmission and conduction of the nerve impulses and the contraction of skeletal and cardiac smooth muscles. It is needed for enzyme action to exchange carbohydrates to energy and amino acids to protein. So it promotes for glycogen storage in the liver and helps regulate osmolality in cellular fluids. If we are to understand what the normal serum level is, it's important for you to understand 3.5 to 5.3 milliequivalents is what we will be evaluating. We want to look at our patients if they start to develop any hypokalemic type of signs and symptoms. It would occur close to or less than 3.5. Those signs and symptoms may be nausea, vomiting, dysrhythmias, as well as any type of abdominal distension or soft, flabby muscles may be present with the patient, right? If the patient starts to develop any hyperkalemic activities or signs and symptoms, it may present if the patient's serum levels are greater than 5.3 milliequivalents. If that is the case, most common causes are renal failure and medications that interfere with potassium excretion. Renal disease or kidney failure results in potassium accumulating in the intravascular fluids, and hypokalemia starts to present itself. Signs and symptoms would be cardiac dysrhythmias. You may see some changes in the EKG rhythm, and the patient may start to develop tachycardia, followed by bradycardia. And you may see some numbness in the face, or paresthesia in the face might be present. The tongue, the hands, and feet. There also might be some GI hyperactivity causing the patient to have nausea and diarrhea present, along with abdominal cramping. So metabolic acidosis may also result or be present with hyperkalemia. Management would be to correct the deficiency or the excess, right? It could be administered orally or IV. It must be diluted, and what we have to make sure that we understand is if potassium is to be administered IV, only 10 milliequivalents per hour can safely be administered to a patient. There is foods or fruit juices that are high in potassium and vegetables that we have to make sure that we educate our patients on as well. Please make sure that you refer to the nursing process on page 234 in your book to understand how important it is for the nursing process to be taken into consideration when we're administering potassium to our patients. Sodium is our major cation in the extracellular fluids. The normal serum levels of sodium is 135 to 145. If a patient is hyponatremic, it would be less than 135, and hypernatremic would be greater than 145 milliequivalents would be monitored for that patient. The most serious problems associated with serum deficits are cerebral dehydration and seizures, as well as coma could be present for the patient. So it's important for us to make sure that we understand how sodium functions in the body and what signs and symptoms could be present. Sodium is found in most of the body fluids and does play a major role in the fluid volume balance itself, and is the primary determinant of plasma osmolality. Sodium combines readily with chloride or bicarbonate to promote acid-base balance. So it is very important for sodium to be maintained or monitored whenever we're going to be assessing our patients. If we're looking at hypernatremic type of situations for the patients, it is caused by a sodium gain or sodium retention or a water loss, which causes excessive oral sodium intake, deficient water intake, and hypertonic tube feeding that may be present for our patients. These signs and symptoms that could be present could be a dry, sticky mucous membrane. They could be flushed, dry skin, agitation, elevated blood temperature, rough, edematous, dry tongue. Patient also might to develop some loss of consciousness, anorexia, tachycardia, and again may develop a seizure or even a coma, would be signs and symptoms of what we want to make sure we monitor. Please refer to page 235 and 236 in your textbook to understand the nursing process in regards to how we would implement it whenever our patients are taking sodium. Signs and symptoms of hypocalcemia is an elevated serum calcium and may be a result of hyperparathyroidism, of malignancy, or hypophosphatemia, excessive calcium intake, prolonged immobility, multiple fractures, and drugs such as thiazide, diuretics, and steroids. Signs and symptoms that may present will be fatigue, muscle weakness, depressed deep tendon reflexes, confusion, impaired memory, anorexia, nausea, vomiting, constipation, and kidney stones. There could be EKG changes, and it could include a shortened QT interval and ST segment. The patient may exhibit decreased heart rate and dysrhythmias with hypercalcemia. Please refer to the text on page 238 and 239 for ways the nursing process could be assessed when patients are taking calcium medications. Signs and symptoms of hypermagnesemia are 2.5 milliequivalents per liter or more than 3 milligrams per deciliter. It's important for us to make sure we understand foods that are high in magnesium, which are green leafy vegetables, fruits, fish, seafood, grains, and peanut butter. If we are to, magnesium can be given IV, and it's important for us to make sure that we understand the proper functioning of magnesium. Please refer to the text on page 240 to understand how the nursing process is used with the administration of magnesium for our patients. Chloride is the principal anion in extracellular fluids. The normal serum range is 95 to 108 milliequivalents. The major function of chloride is to work together with sodium. Sodium and chloride frequently work in combination. For example, during sodium retention, chloride is also frequently retained, resulting in increased water retention. Hypochloremia is a decreased serum chloride level, and the signs and symptoms or clinical manifestations include tremors, twitching, and slow, shallow breathing. Hypochloremia is an elevated level of chloride, and the clinical manifestations seen here are weakness, lethargy, deep rapid breathing, and eventually unconsciousness is present with the patient. Phosphorus is found in both intracellular and extracellular fluids, but it is the primary anion in intracellular fluid. Similar to calcium and magnesium, serum phosphorus are not reflective of true concentration of the body's phosphorus. The majority of the body's phosphorus is found as phosphate. These two terms are used interchangeably. Both phosphorus and calcium levels are regulated by parathyroid hormone and need vitamin D for absorption from the GI tract. Serum phosphorus levels are decreased by PTH stimulation of the renal tubulus to excrete phosphorus. Normal serum phosphorus is 1.7 to 2.6 extra milliequivalents per liter. 50% is ionized or free. 45% is protein bound. That is, 55% is ionized or free, or 45% is protein bound. Phosphorus is essential in bone and teeth formation and for neuromuscular activity. Phosphorus is an important component of nucleic acids and assists in energy transfers in cells. Clinical manifestations of hypophosphatemia include muscle weakness, tremors, paresthesia, bone pain, hyporeflexemia, seizures, hyperventilation, anorexia, and dysphagia. Symptoms of hyperphosphatemia are similar to those of hypocalcemia, including reflexia, tetany, and positive tremor.